All right, so this is part whatever. I don't even know. It's been so many parts of the SNL cardiology questions. I went a little slow on this, but I taught you a lot so far. Couple announcements before we start. One, go on to the like and subscribe to the channel. Go onto the playlists and see other question banks there. Right. I have everything organized there very neatly. Other announcement is that in the description there's going to be an email or something like that that you can communicate with me if you want to give me ideas or whatever. Ask me a question. Feel free to communicate, contact me there. All right. So we were here. 8-year-old dude has okay 3-day history of these things: fever, abdominal pain, and arthritis. Uh, Sore throat 4 weeks ago. Right. Temperature is a little high. Has a fever. High pulse. Okay. Pan-systolic murmur heard on at the apex, right? Apex means mitral. This guy got mitral, a mitral problem. It's pan-systolic, right? So it's a mitral. Systolic means when heart is contracting. Remember, mitral, blood comes to the heart from mitral. So if the heart is contracting and you hear a murmur at mitral, it means blood is regurgitating out of mitral. So it's got mitral regurg, right? Uh, this guy also got C-reactive protein. Just got an infection. Now has mitral regurgitation. This is mitral. So wait, prolonged PR interval. Interesting. Okay, prolonged ER interval. And then talking about the germ, like bacteria, what bacteria causes. So this is by GAS, right? Group A strep, and it's strep pyogenes, also the other name for it. Basically, this bacteria, one of the valence factors it has is M protein. What does M protein do? That's one thing. The other thing is M protein looks like the M stands for myosin or something, myocardia. It looks like the heart, right? So when the immune system is mounting an immune system against the M protein, it is also co-reacting with the mitral valve, right? And it can cause valve problems like that. The problem starts as a regurgitation, but later in life, right? Later in life, this person will develop a mitral stenosis, and even it's not as simple as that. Uh, it's even when it's regurgitation to like later, it's like there's regurgitation plus stenosis. It's just that so like the valve doesn't do any of its job properly. Also, about the function of the M protein, I believe it stops the complement system. Okay, I believe that's is involved in blocking complement activation. Okay, uh, and so it's talking about the organism. So catalase positivity, all the staph organisms are catalase positive. No strep organism is catalase positive. And you can kind of connect that to chronic granulomatous disease of childhood, that these people have problem with staph organisms because because they're catalase positive and not strep organisms because they don't have catalase, and those people, they don't have catalase themselves and need the bacteria to have catalase. um, Actually, it's not that they don't have catalase themselves. If the organism doesn't have catalase, it doesn't get rid of hydrogen, um, like hydrogen peroxide, and then they use that to kill the bacteria. Uh, Coagulase positivity. Now, coagulase, I think, is specifically Staph aureus out of all the staffs that is also coagulase positive. Uh, Optochin is when you're talking about optochin, we're talking about pneumococci versus verdant species. Viridins are optogen resistance. Pneumococci are optogen uh, sensitive. When you're talking about strep, you're talking about bacterial lysin, right? Know that it comes up multiple times, but I'm still gonna check. Be wrong. Where was this? Yeah, here. Pyogenes. Novo Biosyn is for staph. Again, I don't know if like what's resistance, what's not. 81. So this hasn't come up a lot, but Optochin has come up and Bacteriocin has come up. 58, no, 85-year-old progressive dyspnea, uh, had MI 2 months ago. Jugular vein distension, decreased ejection fraction, decreased diastolic filling. Hmm. Okay. You got jugular vein distension. That means blood isn't going back to the heart properly, right? Or the heart isn't getting rid of the blood that's already in it. Decrease ejection fraction, you know what that is, and decrease diastolic filling is basically tell us like the venous distension part. And then it says it doesn't even talk about what it is right now. It says what does it mimic most closely. Let's talk about what. So stable angina is just pain, right? It's not that. Uh, Chronic rheumatic heart disease, that's blood not going back to the heart properly. Okay. So it kind of mimics the first part of venous distension. Mitral regurg, kind of the same, mimics that part, but decreased ejection fraction is not seen in either one of them. Okay. But to be honest with you, dilated cardiomyopathy has both. It has decreased ejection fraction, and because it can't get rid of that blood, it will pull blood before it, right? So it will give us pretty much, and probably this patient does have something like that. What a bad question. I'm gonna say it's actually dilated cardiomyopathy. They don't have the best answer. Right? Yeah. I'm gonna stick to my answer. 78-year-old, uh, smoking a lot. Again, pulsating abdominal mass. We're talking about aortic abdominal aneurysm. Biggest risk factor: smoking. As this guy did a lot. It happens in old guys, as I mentioned, right? What is the pathophysiology? Atherosclerosis. How does that happen? Atherosclerosis blocks oxygen penetration into the aorta. Aorta dies slowly, loses its kind of like patency, and you get AAA. Do you remember when you have to replace it or get a surgery? If it's bigger than 5.5 centimeter, or if it grows more than 1 centimeter per year, or if it grows more than zero point 0.5 centimeter per half a year, which is 6 months, right? It's kind of a step two thing, but it's really important. And if it ruptures, you get hypotension, you get the mass is kind of growing, you get shock. It's a surgical emergency. Albert Einstein died this way. Cool point to know. Okay, 56-year-old. Something is going really wrong. Okay, 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 okay. VMA. I already saw VMA. You can't take that away from me. It's a pheochromocytoma question. Pheochromocytoma is characterized by super high blood pressures, and then like it's normal, and then you get an episode of super high, and it could be normal for like these are days, right? And this can happen like in 20 minutes or whatever. So it's they don't always have super high blood pressure, but when their blood pressure is high, it's super high. It's high enough to cause what? It's high enough to cause uh, basically necrosis of the uh, fibroid necrosis of it's called malignant hypertension when it's above a certain threshold. This is not high enough, but I think it's above 200 over like 110, something like that. Doesn't matter exactly where it lies, but if it gets around there, as it does in pheochromocytoma, then you get fibrinoid necrosis. You can also get fibrinoid necrosis. The way that looks in pathology is that you got like your vessel, but then there's a lot of like super pink stuff around it, right? Something like this. Pink stuff don't have nuclei, so it tells you it's dead protein stuff. Pink proteins show pink on H&E. When it doesn't have also a nucleus, you just like that's basically dead stuff. Fibrinoid necrosis, right? So next question is a 40-year-old guy or woman who's pregnant for the first time. The alpha AFP is lower than normal, and but beta HCG is elevated. Estriol levels are three quarters of normal. So okay, whatever. I don't barely remember these, but estriol is the estrogen that's produced by the placenta, and this guy, what it does is an indicator of how healthy your placenta is, and then this stuff is just telling me like there's some sort of abnormality. Now, what is abnormality? Okay, well, trisomy one of the chromosomes. Um, okay, so I'm just gonna like go on a limb and say this is talking about this guy, right? And just because it's a cardio unit, and just because like none of the other ones can really be predicted, but this is a good one. Um, so paradoxical emboli happen when you have atrial septal defect. Really, if you have any type of septal defects, because emboli usually happen in the vein system, right? And when they go up, when they go into your heart, they gotta hit your lung next, right? And you usually don't feel it like it unless it's ginormous, right? Uh, but if there's a septal defect, it can go across and hit your brain, hit somewhere important, cause ischemia, cause uh, infarct of that part. If it's the brain, it's a stroke, right? So the fact that this thing exists, and maybe so if you have a septal defect, you get an emboli. It's called a paradoxical emboli, and the significance of that is that one way, the normal is just a lung, you probably stay asymptomatic. The other way, you might have a stroke. So it's a big and these are pretty common. The atrial defects are common. So that's why this point is kind of high yield, and I keep seeing it because it has kind of like there's a lot at stake for the patient, and tells you the baby has Down syndrome. Doesn't really matter. I mean, it does matter, but I wouldn't be able if you didn't give me the choices, and I didn't know if it was a cardiology question. I wouldn't be able to tell out of these findings if it's Down syndrome or any other of the trisomies. It's just I would go with Down because Down is the most common. So we got 43-year-old man comes to the cardiologist. He gets syncope for some reason. Uh, hadn't seen a physician for 20 years. History of positive SCD tests for gonorrhea. Hmm. And you got your VDRL and P and RPR. These are for syphilis. So he's got syphilis. Uh, and he got high pitched diastolic decrescendo murmur on occultation. Okay, let's analyze this. Diastolic, early diastolic, decrescendo murmur. All right. These gumas are something that's you see with tertiary syphilis. It's literally just destruction of a set of tissue by because syphilis destroys your best vasculature, so the tissue also gets destroyed. It's kind of like a ischemic type of situation, like an infarct. Um, so okay, early diastolic decrescendo. Decrescendo is kind of like high to low really fast. So what that makes me think of is like something getting ejected into something, and uh, early diastolic. So when the heart is relaxing, something is getting pushed right back at it. Right. This just makes me think of our beloved aortic uh, insufficiency. Right. Aortic insufficiency means insufficiency when you're talking about the valve. It means regurg. It means it's not holding blood back. It means it's leaking back in, right? And that happens because it all makes sense because syphilis it destroys your aorta. So if this is your aorta, right, it destroys it, like it causes endarthritis and to destroying the venoviscorum, and that leads to dilation of the aorta. So your the aorta looks like some like crazy dilated like this, whereas it used to be like reasonably thin, right? And that pulls on the edges, so the dilated aorta pulls on the edges of the valve, and it makes the valve not close properly. Okay, now you know how it works. And so, what is the question asking us? What is a possible complication that is seen in this patient? Uh, okay, yeah, C. I told you the whole story, but this was asking for a specific part of it. It's talking about the end arthritis. What? When did I see those questions? 85. Yeah. These questions are non-renal. I don't know why I label them as renal. The vasculitis questions. At least this one is. So 56-year-old man, sinusitis, boom. First of all, it's a Cianca. So I'm gonna quote my favorite person ever. That's a Pathoma guy. So Wegener, think of it as Wegner, and the C is basically clues you into Cianca. And if this is like a human body, right? The C is draw a C here. It includes things like lungs. So you got your lungs here, your kidneys here, and you got your nose here somewhere, right? These are the three things it hits. I mean, the guy got Wegener's. That's the answer. And Wegener's is grammatosis with polyangiitis. Yeah. This is also vasculitis question. We got a 66-year-old Jewish guy, pain in his right hand. Uh, he's got hypertension, diabetes, type 2 chronic obstruction, pulmonary disease. Okay. Uh, it's kind of smoker. His hands are cyanotic. Okay, so this is thromboobliterans, whatever. Yeah, thromboangiitis obliterans. Basically, the other name is burgers or whatever, burgers. Important things to know about it is one, pathophysiology is explained by a name thromboobliterans, right? There's in the vessels there's thrombosis that just obliterates what's left, right? So thrombosis is a big part of the pathophysiology. Number two thing is that they're related to smoking. Smoking is the cure for them. If they stop smoking, they'll like it does magic for them. But if they don't, they will lose all their digits. And the other thing is Raynaud's phenomena. It's this thing, cyanotic hands, and at the end they get gangrenous. They just like the finger dies. Another thing is that because the artery, like the main arteries of the finger, like die. So if this is like a finger, it's a nail. So these guys will start like making new arteries that look like little spirals. You can see them through when you're doing angiography. So spiral art new, or so neovascularization is also a sign of this, because it means like the main vessels are dying, dead, whatever. So this 3-year-old girl has 7-day history of fever. Okay, basically it's describing, if you have a little girl, she has kind of a fever, kind of like it sounds like it should be like a viral infection. Yeah, conjunctival, and then they got like hand rash and feet rash and swollen lips, like skin lesion. This is Kawasaki's disease, right? And you get coronary aneurysms. Keep that in the back of your mind, right? What do you give them to cure it? You give them aspirin. You don't give aspirin to a kid any others in any other case because of something like something known as race syndrome. Basically, the virus changes the way aspirin. If the child has a viral infection, the virus changes the way liver processes things, and that leads to the liver creating something toxic out of aspirin. So you don't give a child aspirin unless you got this Kawasaki, and if you do, you give them aspirin. Otherwise, they'll get coronary aneurysms. God, I hope I can finish this in this part. 12-year-old uh, has a dentist to get tooth removed, and now has some endocarditis, right? What is your diagnosis? This is my no, not that, no, take it back. No growth, right? No growth. Gotta be Hackett organisms, and he is a. That's basically the guys that don't. Sanguinus. Which one of them is that? Sanguinus is a new name. Strep. Formerly known as. Hmm. Okay. Yeah. Okay. Look. I don't know what's going on. I don't know what's going on here. But if sanguine is the same as viridin, I don't know. I don't know the new name. It could be bovis. Right? If it's viridin, it's found in the oral cavity, and that's where you get the endocarditis. I don't. If it's bovis, I don't know. I don't. It shouldn't be bovis. Okay. 45-year-old has there's a EKG shows an infarct. That's anterior medial area of the infarct, transmural anterior medial infarct. Develops a cardiogenic shock. What do you see? 4 days, right? 4 days. 4 days. So day 1, 2, 3, like you see all the neutrophils getting right. It's acute inflammation. There's a lot of damage happening. But around day three, like you start building stuff, so you see um, macrophages moving. So I'm looking for the term macrophages. There's one over here. Nothing else has really macrophage. I'm gonna go with that. All right. So last question. Yeah, verdin is sanguineous. Oh, I knew that. I knew that. I completely knew that. So at day three, you get neutrophils. At day four, you should get macrophages, right? So day three is where the transition is. I don't know why this question has said day four up here and then day three down here. But day three is where the transition is from neutrophils to macrophages. And macrophages are when you get all the problems. So neutrophils, the problems they give is like uh, pericarditis, but macrophage, the problems the macrophages have is they kind of like destroy the existing tissue to build new stuff, and that causes looseness, that causes all the ruptures that you see. So we got a 67-year-old uh, physician now prescribes a medication that I explained. Okay, so if you're taking a medication that causes flushing, in this context, it's niacin, vitamin B3, right? And it causes flushing through prostaglandins. That's why you give them like an NSAID to block this action. So the antidote to this is NSAID, and it's caused by niacin. And niacin is mainly increases HCl. Doesn't do much else. All right, so 24-year-old jugular vein distension, systolic murmur burst at tricuspid. Okay, tricuspid valve. This is where all the veins go to, right? This is where, if you're a drug user, this is where you get infections, right? And if you're a drug needle user or intravenous drug user, you're cutting open your skin a lot. Your skin has a lot of Staph aureus. That's why you get Staph aureus infections, and these are more virulent, meaning they're faster to damage the valve than the one we talked about in the case of the little child who was at the dentist with the sanguinus, which is a verdant species. Right. Okay. So in this case, we got a 40-year-old African American man has hypertension. Holy, super high hypertension. What are you gonna see? Hyperplastic arteriosclerosis. This is very similar to the five. It looks different, right? This looks kind of like an onion skin, but it's like same idea as fibrinoid necrosis of the vessel. That we saw a few questions ago in a pheochromocytoma patient. Also, if you see this question, like in this kind of a simple question, in a more complicated question, like this has got to be your main concern. I said earlier in this question series that like if the patient has an abnormal blood pressure, like be concerned about what's going on with the patient most acutely. Just don't read over vitals and be like, oh, I'll get back to this. No, that the vital you see will change the question's fate forever. 3-year-old boy is itchy on his face, soles, and feet. Lymphadenopathy. So this guy has got Kawasaki syndrome. We give him aspirin, IVIG. IVIG is basically these are just antibodies against like no particular target, right? But what they do is that the FC region will bind like the FC receptors on leukocytes and it deactivates them. It causes negative feedback. So it's useful for like stopping antibody secreting cells. Uh, Again,